Alterations in mobility, traumatic musculoskeletal injuries. Injuries to the musculoskeletal system can potentially cause dysfunction to the muscle, injury to blood vessels and nerves, or skeletal dysfunction. Treatment will involve immobilization of the injury until it's healed. A strain injury is going to be when a muscle is stretched or pulled beyond its capacity. There's three types of strain. We have first degree, where we have a mild stretching but no loss of function. The pain occurs with full range of motion. A second degree strain, we have a partial tearing of the muscle or tendon, limited motion, an inability to bear weight, and ecchymosis. And a third degree strain would be severe muscle and or tendon tearing, severe pain, and loss of function. A contusion is soft tissue swelling resulting from a blow or blunt trauma. Not necessarily swelling, but soft tissue injury. A sprain would be an injury to a ligament surrounding a joint that involves a sudden and unusual movement or stretching, twisting, or displacement of the joint beyond the normal range of motion. And this causes a partial tear or rupture of the ligament attachment. The three types of sprain are going to be a first degree, which we have stretching and pain with movement. The second degree is going to be a partial tearing of the ligament, and we have some loss of function. The third degree, we have a complete tear or rupture of the ligament and possible bone fracture detachment, which is called an avulsion fracture, and definitely abnormal joint movement. This is most common. The strains and sprains are most common in the wrist, elbow, knee, and ankle. These clients have immediate pain followed by swelling, ecchymosis, and joint instability. We diagnose by physical exam, x-rays, arthrography, and arthroscopy. We're going to initiate PRICE or RICE. We need to protect that joint, rest it. The I is going to stand for ice, ibuprofen, and immobilization. Ice, ibuprofen, immobilization. The C stands for compression, so usually like an ACE wrap, that elastic bandage. And E is elevation. We can apply heat when edema is unlikely, usually 2 days post-injury. Medications, usually we're just going to give the NSAIDs. And progressive physical therapy. It's very important that we protect this site from further injury until it's healed. It's going to be very susceptible to re-injury if it does not heal appropriately. True or false? An acronym for the appropriate management of strains, contusions, and sprains is, I'm assuming that says RICE, and that is true. We can add an S to the end of RICE and put that S as stabilization, which, could also be immobilization, or PRICE would be protection. Dislocations are going to occur when the articular surface of a joint are no longer in contact. It happens usually from trauma. Compartment syndrome, which is a compression of structures in a confined space, can lead to pain and palsy, which would be decreased sensation and movement that can become permanent without treatment. We could also see Volkmann's contractures and complications. And I'm going to tell you compartment syndrome is going to be a complication of some of our musculoskeletal injuries where we have so much edema from the injury that it now compresses inwardly and begins to affect our circulation and begins to affect nerve function. When we have compartment syndrome, what is happening other than that edema and the loss of circulation, the loss of nerve function, that client is going to have significant pain that is not managed by pain medications. And the distal portion from where that compartment syndrome is taking place, they're going to start showing signs of decreased circulation. So we're going to see edema, we're going to see pallor of the skin, and we're going to have decreased pulses or cap refills. So really important to monitor for compartment syndrome. Common sites of dislocation include a shoulder, hip, and knee. A partial dislocation is called a subluxation. These clients may hear or feel a popping sound. They have a sudden instability of that joint and pain, and they have an altered structural shape. They can have a lengthening and or shortening of a limb, limited range of motion, swelling, and paresthesias. We diagnose with x-rays by doing orthography or arthroscopy. We're going to treat it by manipulation to get it back in place, and then we immobilize the joint. Surgery may be required to reduce a dislocation or repair any potential damage. We manage it with pain medication. Nurses need to also do neurovascular checks, elevation, immobilization, and cold packs. Ligament and meniscal injuries. These are traumatic injuries from a blow or a twisting motion with hyperextension of the knee. Meniscal injuries are usually going to occur with a twisting motion or something like repeated squats. These clients will have pain, instability, ambulatory difficulty. They may hear or feel a popping or tearing sound or have locking of the knee and clicking with ambulation with a meniscal injury. We treat it with NSAIDs, ice, and immobilization, limited weight bearing, but progressively increasing that activity, and potentially surgery. Fractures. This is a break in the continuity of a bone, and it can also affect surrounding tissues or organs. We have a sudden direct or indirect force that causes that bone to break, or there may be bone weakness. Older adults are going to be more prone to fractures due to increased bone resorption and decreased bone formation. Now, a common fracture that is seen, especially in the older adult, because if they trip and fall or lose their balance, they reach out that hand to try and break their fall, and then they have that fracture in the wrist. And this fracture kind of looks like a dinner fork or a swan's neck. Um, they call it a colles fracture, Colles. So that's a common fracture that we see when a person tries to break their fall by stretching out their arm. We have different classifications of fractures. We have an avulsion fracture, which is where a fragment of bone is pulled away by a ligament or tendon. We have a comminuted fracture where we have splintering of the bone. A compound fracture where the bone extends through the skin or the mucous membrane. A compression fracture where the bone has been compressed, such as a vertebral compression. Let's say, for example, an older lady has osteoporosis. So those bones are kind of porous and they're brittle. She falls on the floor on her butt and it compresses the vertebrae. So now she has that compression fracture. We can see depressed fractures where fragments have been driven inward. This would be commonly seen, for example, with a skull fracture, uh, where the bone fragment is driven into the skull. An epiphyseal fracture would be a fracture that occurs through the epiphysis of the bone. A green stick fracture, this one is commonly seen in children because their bones are not as hard as an adult's. So one side of the bone is bent and one side is broken. An impacted fracture is where that bone fragment is driven into another fragment of the bone. An oblique fracture is one that occurs at an angle across the bone. That pathologic fracture is the fracture that occurs without injury. It's usually in diseased bone or bone that is very low in calcium. A simple fracture does not break the skin. Sometimes it's also called a closed fracture. A spiral fracture, we have a twisting around the shaft of the bone for the fracture. And transverse is a fracture that goes straight across the bone. So when a client has a fracture, they frequently will have a loss of function. They're going to have pain. They may have deformity. They may have false motion or crepitus, where the ends of the bone grind together. Edema, muscle spasms. Muscle spasms are often seen in femur fractures. I mean, think about the femur. It's stretching the muscles of the thigh and keeping them in a certain position. And if we have a fracture where there's displacement, then those muscles are shortened and they begin to spasm. That's why traction is often a great um, pain relieving tool and immobilizer for femur fractures. We may also see nerve damage. We diagnose with x-ray and or a bone scan. So stages of healing of a fracture. First of all, we have a hematoma formation. This begins immediately after that bone is fractured and blood seeps into the area and it forms that hematoma or that blood clot. Fibrocartilage formation happens about a week after the fracture, where osteoblasts form and the clot begins to retract. Callus formation happens about 3 weeks after the fracture. A procallus will form first, and then it just helps stabilize that fracture. Stage 4, we have ossification, where a callus with the bone cells form after about 6 to 12 weeks. And then in 3 to 4 months, the osteoblasts begin to remodel that fracture site. Consolidation and remodeling is stage 5. And if the fractured bone has been accurately aligned during healing, remodeling is going to be complete in about 12 months. The goal of caring for the fracture is going to be to reestablish functional continuity of the bone. So we can treat it with traction, closed or open reduction, internal or external fixation, cast application. And if there is a cast applied, people want to know, how long do I have to wear it? Well, the cast usually will remain in place until that bone is strong enough to withstand mild stress. So at least 3 weeks, average of about 6 weeks. And these clients may require a brace after the cast comes off for additional support. They may also require the use of walkers or crutches. Factors uh, for treatment are going to include the location and severity of the fracture, the age of the client, and the client's overall physical condition. As far as nursing management, we're going to do our neurovascular assessments, assistance with ADLs, promoting mobility, prevention of complications, cast care, and an immobilization device use, and education on traction. Fracture complications include shock, fat embolism, which this is pretty particular to a fat embolism. We have petechiae develop on the upper chest along with dyspnea. It usually will follow the fracture of a long bone, usually in the leg or the hip. But a fat embolism is just like a clot embolism, but it's a piece of fat instead of a blood clot. Pulmonary embolism, compartment syndrome, delayed bone healing, which would be failure of the bone to heal at an expected rate. The older adult, however, may heal at a slower rate. We consider that to be normal. Non-union, where the ends of the bone are not aligned. Malunion, where the ends of the bone heal in a malformed position. Infection, avascular necrosis, which is death of the bone from insufficient blood supply, and complications of immobility. So a fractured femur is going to occur from a fall or an accident, such as a motor vehicle accident. These clients have severe pain, swelling, and bruising, and again, those muscle spasms, just as I discussed. We treat it with traction. They may require an external fixator or spica cast or surgery to repair that fracture. Nurses, we have to prevent immobility complications. And if there is skeletal traction or external fixator, we need to make sure those pin sites are cleaned on a daily basis. The pin sites are usually going to be cleaned with an appropriate cleanser. Then realize this is going straight into the bone. So we're going to wrap the Xeroform, which is a petroleum-based gauze, around the pin site to help prevent the migration of bacteria along that pin site, and then cover it with a gauze bandage. Again, this is done every day. With the hip fracture, this usually does involve the fracture of a proximal end of the femur or femoral neck caused by falls, a bone disorder, or trauma. And it occurs most often in older adults with osteoporosis. The hip usually involves a fracture of the proximal end of the femur or the femoral neck. These clients have severe pain. They have shortening and external rotation of the leg. This is very classic sign of a hip fracture. So if you look at the picture on your slide, you can see that the one leg is shortened and it's rotated outward. These clients also have blood loss. There's a lot of blood in those bones. They may have extensive bruising at the fracture site, edema, contained bleeding, and muscle spasms. Again, we would diagnose with x-rays. We're going to put these clients in traction, usually a Buck's traction. They may use an external fixator. They may use a spica cast. They may have a total hip arthroplasty or hemiarthroplasty. So we need to prevent immobility complications, clean the pin sites, position the client appropriately. Remember, with hips, those legs have to stay abducted. In other words, we have to keep them separated.